Good morning, respected teachers and dear friends. Today's topic for presentation is slowing, asymmetry, and suppression in EEG. This session will be chaired by Dr. Ashalatha Madam. So, coming to the normal EEG frequency bands and standard frequency classification, delta wave, it's 0.5 to 4 hertz, slowest with the highest amplitude, seen in the deeper stages of non-REM stages 3 and 4. A persistence of delta in awake adult is a sign of cerebral dysfunction. Theta waves are 4 to 8 hertz, drowsiness, seen in drowsiness and transition to sleep, seen in children as a normal background rhythm. This is linked to memory, encoding and retrieval and deep meditative states. Excess theta in an awake adult can indicate diffuse brain dysfunction. Alpha waves are 8 to 13 hertz with the rhythm seen as a rhythm of a relaxed, wakeful state with eyes closed. And the alpha waves typically disappear when the eyes are open or while performing a mental task. Beta waves are 13 to 30 hertz, seen in alert, focused, and actively thinking state, also seen with the use of benzodiazepines and barbiturates, often seen symmetrically over the frontal lobes. So there are many classification systems for EEG reporting. One of the commonest classification used is Mayo Clinic classification. First, there are 4 different categories: asymmetry, dysrhythmia, delta, and suppression. First, we'll be seeing dysrhythmia and delta. Dysrhythmia is the intermittent slowing that is seen, and this is divided into grade 1, 2, and 3 based on the voltage criteria, or it can be divided based on a visual impression also. So this 1 and 2 is the intermittent non-specific slow activities, whereas this 3 is a specific electric interictal epileptiform discharges or photoparoxysmal responses, temporal intermittent rhythmic delta activities, or electrographic seizures. Whereas delta is a continuous slowing which is seen throughout the record, which is divided into grade 1, 2, and 3 based on the voltage criteria. Less than 30 is grade 1, 30 to 60 is grade 2, more than 60 is grade 3, or this can be classified based on the visual impression. So these are persistent polymorphic slowing. So coming to the slowing in EEG, what is slowing? Emergence of frequencies that is below the alpha range in an awake adult EEG recording. It is a common and non-specific sign of cerebral dysfunction. So how to approach a slowing in EEG? We have to see whether it is continuous or intermittent, whether it is reacting to eye opening, eye closure, or any visual stimuli, whether it is persisting in various states of wakefulness and sleep, and define the range of amplitude and its variation with awake or sleep state, and define the localization. So we will be describing it based on the distribution of the slowing, whether it is posteriorly located or focal. Focal means it is a sublobar localization of a lobe. And multifocal means more than 3 areas, spatially distributed areas are involved. Regional means a lobe is localization of a lobe. It can be either a frontal, temporal, like that. And hemispheric, one hemisphere, and generalized diffuse involvement will be there. Frequency, whether it is in the theta frequency or in the delta frequency, whether it is coming intermittently or continuously, rhythmically or not, it is coming monomorphic as or polymorphic, and whether it is reacting to a variable eye stimulus, visual stimulus, or the state of vigilance. So when is slowing normal? Normally, drowsiness and sleep are the most common causes of slowing, and there will be age-related changes. Like in infants and children, there will be a slower posterior dominant rhythm, and elderly, a mild generalized slowing can be normal. Also, in hyperventilation can induce a generalized high amplitude rhythmic slowing, which results post hyperventilation. And what is pathological slowing? A slowing that is not explained by the patient's age, or the level of consciousness, which reflects a disturbance in the thalamocortical circuit. So this slowing can be either a generalized slowing, focal slowing, or a regional slowing. So in the generalized slowing pattern, it can be either generalized synchronous slowing, that is bilaterally and synchronously seen over both the hemisphere, which suggests a widespread cerebral dysfunction, or a generalized asynchronous slowing, which is often seen in severe encephalopathies, and a region-wise bisynchronous slowing, which can be either in the frontal lobe, that is frontal intermittent rhythmic delta activity, or in the occipital lobe, occipital intermittent rhythmic delta activity. So here, this EEG I will be discussing EEG in the longitudinal bipolar montage with the standard frequency filter setting at high frequency filter set at 70 Hertz, low frequency filter setting at 1 Hertz, and a standard sensitivity of 7 to 10 microvolt per millimeter. And the first will be the left parasagittal chain, followed by right parasagittal chain, then the left temporal chain, right temporal chain, and the midline central electrodes, followed by the EKG electrodes. And these all these EEGs will be followed by a referential common average reference. So here we can see there is a intermittent slowing that is coming, and in generalized in almost all leads it is coming. So as we said earlier, intermittent slowing is dysrhythmia. So with the uh, low to moderate degree of amplitude of the delta slowing, here it is this one generalized, same as seen in the common average reference. Then coming to the region-wise generalized slowing, that is frontal intermittent rhythmic delta. These are transient intermittent rhythmic slow wave pattern of 2 to 3 Hertz delta frequency with an amplitude of 50 to 100 microvolt, which is predominantly seen in the bilateral frontal region in an awake adult EEG, which is typically occur in adult. In contrast, there is occipital intermittent rhythmic delta, which is seen in children. So here we can 2 to 3 Hertz, almost medium to high amplitude delta activity that is coming predominantly over the frontal region, and that is by in the both hemisphere. So this is frontal intermittent rhythmic delta activity with the previous and the after that background is normal. Same is seen in the common average. So these waves, which are a slanting is like waves, these are called theta waves. Occipital intermittent rhythmic delta activity. These are rhythmic delta activity that are seen over the occipital region with the field that is extending to the posterior temporal or the parietal channel, which are frequently seen in children and considered as an occipital equivalent of the FIRDA. So here also we can see there is rhythmic 2 to 3 Hertz intermittent delta activity that is seen over the occipital region, that is P3O1, P4O2, T5O1 and T6O2. This is called occipital intermittent rhythmic delta activity. Same is seen in the common average montage. So one of the mimic for occipital intermittent rhythmic delta activity is phi rhythm, that is a physiological rhythm. These are posterior waves that occur immediately after eye closure. Here we can see immediately after eye closure there is high amplitude, medium to high amplitude, 2 to 3 Hertz intermittently, which is less sinusoidal and less rhythmic than occipital intermittent OIRDA. So the same is seen in the common average also. These five rhythms are physiological, and it is thought to be a forerunner of occipital intermittent rhythmic delta activity.
It is thought to be once upon a time. It was thought that children show this activity. It's like a signature of absence epilepsy, but that has not been proved. That is how the five rhythm got into the picture, but that is nothing but an oirida, but it's seen only during eye closure. So these are all fancy questions for examiners and all, but otherwise it is nothing but oirida, but seen only during eye closure. So the essential difference is that both are seen in the awake state and not during hyperventilation. One is seen during eye closure, that is what is called the fire rhythm. And fire rhythm, once upon a time during the days of Glure and all, he thought that these children are likely to develop absence epilepsy, which has not been proved by any of the literature later.
So next is here we can see there is a continuous slowing of low amplitude delta waves that is seen in almost all channel. So this is a continuous slowing, so it is delta and it is low amplitude, so it is grade 1 and it is seen in all channels, so it is delta 1 generalized.
See what is see. This is a little tough topic, and therefore I'm interfering in between. So you can see that in the awake state also, nowhere the alpha is coming to the range that we want it to happen, and you can see that there is a slower alpha or probably a theta alpha merging together. But overall, if you see this EEG, you have to put it as a generalized slowing, and this is persisting throughout the record in the awake state when we call it delta. So I'm again clarifying, this is something which is intermittent, should be in the awake state and could be mild, moderate, severe. You don't have to remember about the voltage criteria and all, because it's for research purposes. But delta is the same thing, but it is persistent throughout the record, and all both of them are grouped under the dysrhythmia or the slowing. But the thing is that one, again I repeat, both in awake, sleep, we don't put this classification. It's all based on the Mayo classification. But there is a mild degree of slowing. You have to compare the EEG. When there is a generalized slowing like this, it is to be compared with an age-matched control. Otherwise, when something happens on one hemisphere, suppose this was delta grade 1 left hemisphere, the left hemisphere of that person should be compared with the right hemisphere of the same person. So it's EEG is nothing but a comparison of both the sides or both the lobes. So delta is nothing but this record will be showing this throughout the record. That is what is called delta, and essentially that is the difference between dis and delta.
Here also we can see there is a continuous slowing of high to medium to high amplitude that is seen throughout the record. So it is a continuous slowing, so it is delta 2 generalized. Same in the common average also. And here we can see high to medium amplitude that is seen throughout the recording, which is persistent. So this is a delta 3 generalized. Same in the common average also. Now coming to the focal slowing pattern, focal, as we already discussed, it is a small area usually involving one or two channel. Regional indicates the involvement of a particular lobe, frontal, temporal, like that. And multifocal means three or more spatially separated multiple areas. So this focal slowing also, it can be either a persistent one, that is delta slowing, or an intermittent one, that is a dis slowing. So coming to the this here we can see there is intermittent slowing that is seen over the left frontotemporal region. Left frontotemporal region. So since it is intermittent and of low amplitude delta activity, so this can be classified as this one in the left frontotemporal region. Here we can see some spike and wave discharges that are seen in the left right posterior temporal chain. So as it is spike and wave discharges, it comes under dis 3. Same we can see in the common average, with the highest amplitude is seen in the right T6 chain. It is a dis 3 right posterior temporal.
So dis3 is basically whenever you get a spike, sharp waves, or anything which is epileptiform, dis2 becomes dis3. So again, this is something which is a qualifier in the awake state. So ones which come under that is one is of course all the spike and spike wave discharges, and second is your Tirida. Unlike Firida and Oirida, Tirida has been proved to be epileptogenic and is almost similar to what you get as spike and wave discharges in the temporal region. Second one, then when you qualify the PLEX, that is periodic lateralized epileptiform discharges, which are now known as renamed as PETs, whatever it is, that is also coming under that. And when you get an electrographic seizure in the awake state, awake means patient is partly arousable, at least that comes under this. And all clinical seizures also, clinical and with an electrical pattern accompanying that, that also comes under DIS3. Then there are newer entities like birds and other things and all, but basically these are the ones which qualify as DIS3. So DIS1 is just a mild amount of slowing which is intermittent in the awake state. DIS2 is just a moderate amount of slowing for you. I always tell that for me, maybe it's DIS1, but for the other person sitting with me, it may be DIS2. That's okay. So it is intermittent. And DIS3 means you have it when the epileptiform discharges come into the fore.
So in this 3 we will classify Tirida, that is 1 to 4 hertz intermittent rhythmic delta activity with 50 to 100 microvolt amplitude, which can be either sawtooth or sinusoidal morphology, seen predominantly over the anterior temporal region, more frequently seen in drowsiness and light sleep. This is often linked with the anterior temporal spike or sharp wave that are interictal epileptiform discharges. So here we can see intermittent rhythmic delta activity of 1 to 3 hertz that are coming rhythmically in the temporal region, in the right temporal region. Same as seen in the common average also. These are monomorphic intermittent rhythmic delta activity of 1 to 3 hertz that are coming rhythmically over the left temporal region. So right temporal region. So this can be potential, there is associated with the spike and sharp wave morphology. So there is potential indicator of a epilepsy. Then here we can see there is a continuous slowing in the left temporal region. So as it is continuous, it is delta and it is low amplitude delta activity. So it is a delta 1 left temporal region. Here also we can see a low to medium amplitude continuous delta activity seen in the right posterior head region, mainly in the P4O2 and the T6O2 chain. So this is a continuous slowing. So delta grade 2 right posterior head region slowing.
So if you see the CEG, it's having a generalized slowing that one should understand. So it's a delta grade 1 or 2 generalized. So that is first thing which you have to note, and this is how the Bayo system is so complicated. And on top of that, you see slowing which is coming over the right posterior head region slowing. So if you're going for an electrophysiology exam and the Bayo classification you have to apply here, I would rather put it as a continuous slowing generalized, so delta grade 1 generalized, and maximum over the right posterior head region. And since I find that this is intermittently coming over the right posterior head region, the other way of classifying it is as delta grade 1 generalized and a disc to right posterior head region. So that is another way of classification. This is how it is a very variable thing which only the onlooker will be able to identify it, because you have classified it in one way. I would rather classify it in another way. For her, it's delta grade 2, right posterior head region. It's not delta 2, it's delta grade 2. So that's also correct, but you can add on to it. So there are some eye blink artifacts and all here. And we know that the patient is in the awake state. So that's how it is classified.
Same in the common average also. So here also we can see there is a delta continuous slowing in the left hemisphere. Continuous slowing, ഒരു medium amplitude delta activity. So this is a delta grade 2 in the left hemisphere. Same in the common average also. Here we can see low to medium amplitude continuous slowing that is seen over the bilateral occipital region. So this is a delta grade 2 bilateral occipital slowing. Coming to the second topic, that is asymmetry in EEG. There is a significant difference in the electrical activity between the corresponding regions of the two cerebral hemispheres. Then we call it as asymmetry. So asymmetry is classified as grade 1, grade 2 and grade 3 based on the percentage difference between the amplitude, frequency or reactivity or the morphology or the between the two hemispheres. So if it is less than 50 percentage, then it is grade 1, 50 to 75 percentage, then it is grade 2, or more than 75%, then it is grade 3. A more than 50% amplitude difference is generally considered abnormal, which usually indicates there is an underlying structural abnormality which can be either focal or regional. So, symmetry versus mild asymmetry. So, in mild asymmetry, in voltage, first we consider if it is less than 50% voltage difference between, it's a visual impression. So, if it is a less than 50% voltage difference between the two sides, then it is called mild asymmetry. And if it is a less than zero point 0.5 hertz difference between the sides, then it is symmetric, whereas if it is between 0.5 to 1 hertz difference between the sides, then it is a mild asymmetry. And if there is a more than 50 percentage voltage difference between the two sides, then it is called marked asymmetry in voltage. And if there is a more than 1 hertz difference between the more than 1 hertz difference in frequency, then it is called marked asymmetry in frequency.
So there's nothing to be very much scared about the whole thing. Again, it is mild, moderate, and severe. So it is between the hemispheres that you always compare the asymmetry because you can't pinpoint it to one or two channels. So just have to make it mild, moderate, and severe. Compare between the two hemispheres, and it's not always not at all generalized. So it's a comparison between the two hemispheres, and depending upon the voltage and frequency, you can have just a look at the EEG, and it can be 1, 2, and 3. Hope you understood.
So asymmetry we will consider mainly asymmetry increased activity, that there is a focal increase in the activity which is most commonly seen with the skull defect. This reduces the attenuation of faster frequency, so it is called a breach rhythm. As the electrical potential, it travels from the cerebral cortex then to the meninges, that is the pia, arachnoid and the dura, then the diploic spaces, skull, the subcutaneous tissue and hair. There will be an attenuation of the potential that is being recorded in the electrode. So when there is a breach or when there is a skull defect, these frequencies will be expressed more. So this is called an increased activity in case of a breach effect. That is, activities of higher amplitude and increased sharpness will be expressed, which are primarily of faster frequencies compared with the opposite side of the brain. So here we can see there is a compared to the opposite side, that is right side, there is an increased activity in the left centroparietal region. So there is an asymmetry grade 1 left parietal breach rhythm. Same you can see in the average reference common average. It is this high increased amplitude is seen in the P3 channel. So it is a left parietal breach rhythm. Here also we can see there is an increased amplitude in the left temporal. So asymmetry grade 1 left temporal breach rhythm. Compared to the right side, it is more in amplitude. Here you can see there is an increased activity in the right temporal. So this is asymmetry grade 1 increased in the right temporal.
So breach rhythm, as she rightly told, it's when there is a previous surgery, and the other thing is when there is a trauma, so that the resistance of the other structures between the electrode and the surface of the brain are taken care of to some extent. But don't think that seeing the EEG you have to diagnose that. You'll always have to go back to the report and the request of the patient's EEG that patient had undergone such and such a surgery, and all those stuff only will give you answer that it's asymmetry. But if you see that no surgery has been done, then it is for the technologist, especially if they are in the lab, to palpate that area and see whether there is a fall or a trauma or something which has caused a skull defect in that area. And then there are certain syndromes, congenital syndromes, and all in neurology where the skull defect is part and parcel of the syndrome. So these are the common instances in which there can be an asymmetry. So the striking thing you see here is that there is an alpha. So suppose at what sensitivity? 10. 10 sensitivity, this alpha is okay. But then there is some blink artifacts. But this region is standing out prominently. So there is an asymmetrically expressed activity over the right hemisphere. And this could be due to several reasons. But when I mean, at least when I teach, it's always a breach rhythm. Otherwise, it will be so confusing because I can write this report in various other ways as well. So, suppose I say that the other regions are all suppressed. That is the both the parasagittal chains and the left temporal chain is suppressed. Nobody can negate that. So, this may be normal for somebody. That is why it's a little confusing. But when you are given the fact that it is a breach rhythm, because of the fact that the right temporal or a right hemispheric surgery was done, definitely this becomes asymmetry grade 1 or 2 as you like. Increased, you have to write increased or decreased also. That is a term which is in additionally used in this particular one as compared to this delta, and she is going to speak about suppression. So here increase or decrease is also one term that you should use. So this is asymmetry grade 1, increased right temporal breach rhythm after right anterior temporal lobectomy. Hope it is clear.
The same here also, uh, asymmetry seen in the right temporal, that is grade 1 increased breach rhythm. Here we can see there is an increased amplitude in the left temporal with a high amplitude, and also there can be seen some intermittent slowing also. Here compared to the right hemisphere, there is an asymmetry, that is grade 2 increased in the left temporal breach rhythm. So coming to the last topic, that is suppression in EEG. Suppression also, as it is classified based mainly on the attenuation of the amplitude. So mild means there is a 20 to 30 microvolt attenuation, moderate 10 to 20, and severe means less than 10 microvolt only be visible. So there is a severe cerebral inactivity. So primarily there are two low voltage states. One is attenuation, that is the EEG activity that measures more than 10 microvolt, but it is less than 50% of the amplitude of the higher voltage background activity. So it signifies that there is a reduction in the amplitude, but there is not complete absence of the electrical activity. Whereas suppression is the EEG activity that is consistently less than 10 microvolt, and this indicates that there is a profound reduction or almost near absence of the cerebral electrical activity.
So less than 50% reduction, you see visually it is attenuation. Something which is completely suppressed even at 7, or you can go even down to the gain of 5 microvolt per millimeter. And then there's a flat line that you see, that is what is called a suppression. So attenuation and suppression are used interchangeably, but suppression always denotes a much more a global dysfunction or a focal dysfunction of the brain. So it's better to use the term attenuation when somebody is alive and they are walking into the EEG lab, or a child who is playing around and then doing an EEG. And all. It all depends upon the clinical scenario that you are dealing with. So, but you should know the difference between attenuation and suppression. Suppression is something which is not seen, even seen as a flat line at 10 microvolt, that condition, but you can even change the gain to 7 or 5 even. The other one is just a 50% reduction. You can see some activity, but it is still not up to the mark.
Here compared to the right side, we see a reduced amplitude left side. So this is a suppression, that is grade 1 in the left hemisphere. Same we can see in the common average also. Compared to the right side, there is a reduced amplitude on the left side. Here also we can see there is a reduced amplitude in the right hemisphere compared to the left hemisphere. So this is suppression grade 1.
So this is again very complicated. How do you know that the left hemisphere is normal? The left hemisphere doesn't show this much of fast activity in a normal patient. So, given the fact that there is something happening on the right hemisphere, for example, a right hemispheric stroke has happened, or a right hemispheric porencephalic cyst is there, or the patient has something sitting on the right hemisphere, then you go back and see, and then it becomes suppression grade 1 right hemisphere. But if this EEG alone is given to you, it can be interpreted in very many different ways. This is suppressive force that is there, but here I can put it as asymmetry also. If you do not know, asymmetry grade 1 or to grade 2 increased left hemisphere, because there is an overexpression of the fast activity, which is not a common feature or not at all a common feature in the normal EEG. This much of fast activity is not going to be there in the your routine EEG reading practice. Another way of now, going about this one is that the patient is probably on benzodiazepines or barbiturates. These are the two drugs which can cause a generalized fast activity. And this generalized fast activity is expressed only on the left side, because the left side or the left hemisphere is comparatively normal. And the right hemisphere, you know that there is something which is between the electrode and the brain, which could be anything which is structural, or it could be the CSF that is accumulated there or anything. So you tend to call it as suppression over the right hemisphere. Then earlier there was again confusion. Can we even call it an asymmetry grade 1 decreased right hemisphere? So we didn't bring it to the picture because we are on the verge of taking out this Mayo classification very soon, because it is so confusing. It was thought to be very much good for research practices, and when we go outside and try to teach students, I understood that this is lot of fallacies in this. If I tell that this is asymmetry grade 2 decreased right hemisphere, you have to buy it. I mean, that is also another way of classification. So for the time being, let it be suppression grade 1 right hemisphere. Let us assume that this patient has a huge right porencephalic cyst on the right side, or a right encephaloclastic lesion on the right hemisphere.
Here also we can see a reduced amplitude seen in the P3O1 and the T5O1 chain. So this is a suppression grade 1 left occipital. So some of the focal attenuation mimics are when there is an increased distance between the cortex to electrode that reduces the scalp potential. For example, scalp edema, dural based tumors like meningioma, subdural hematoma. In subdural hematoma, the subdural fluid, the collected fluid that shunt the potential differences, and this is more apparent in a bipolar montage. And there is a preserved cortical activity, only the low inter-electrode voltage only varies. And the salt bridge or the electrical bridge phenomena that is confined to one channel, this is also seen better in a bipolar montage. It looks like a focal attenuation, but this is an artifact. So here we can see suppression only seen in the P3O1 channel, seen in the as we can see in the average common average reference. This it is not seen.
So this is an attenuation which is confined to the P3O1, and maybe you can pass it off as a normal thing, because if you compare with P4O2, it is not very different. But for again a technologist sitting there, they may be knowing that you apply a gel between the electrode and the surface of the skull, so that that gel is actually a conductive medium to increase the amount of activity that is reflected onto the electrode. So it is something which increases the conductivity of the potentials from the brain to get expressed over the surface of the brain. But what happens is, and before that, when there are two electrodes, there should be a potential difference between two electrodes to be picked up as an electrical activity and get expressed on the surface. So if, for example, P3 and O1, if P3 has plus 10 microvolt and O1 has plus 5 microvolt, then there is a difference. But if P3 and O1 has both plus 10 microvolt, then you won't get anything. As it passes through the differential amplifier will see it as a zero voltage, and therefore this can happen there also. But in this case, what is known as a salt bridge is because there is a gel which traverses from one electrode to the other electrode, and it causes sort of a bridge, so that the potential in this one electrode becomes almost equivalent to the other electrode, and therefore it can appear as a flattened line. If you ask, there is a total, the whole EEG is not normal, because because there is a relatively low voltage activity which is seen throughout the record, which may be due to 101 reasons. But just to introduce the term of what is called a salt bridge, this is what salt bridge is. And what is the problem with that is that it is only actually seen in the referential, it is seen in the bipolar montage. And when you put it in the referential montage, it is picking up only activity in one electrode. So both the electrodes have a potential, but when they are, plus or minus them, you get a potential difference. But when you take it only on one electrode, that gets nullified. So this is the importance of salt bridge. It can be there in bipolar montage, but when it comes to the referential montage, sometimes you may not see it. There is a classical example here. Okay.
So here we can see as the technical error is corrected, their amplitude is picking up in the P301 channel.
So you can compare this one with this one. So if you have very good technologists and all of them are sitting there who are the backbone of our electrophysiology department, they'll pick it up and then immediately correct. Otherwise, the whole EEG recording will go on and off like with this salt bridge there. And if you have some activity which you want to pick it up in that particular channel, it will completely be gone because of the fact that it's a technical error.
Lack of electrical activity recording from the brain exceeding 2 microvolt when appropriate recording techniques are used. That is, with a full set of electrodes including midline electrodes, inter-electrode impedance between 100 to 10,000 ohm, and we have to verify the integrity of the recording system by tapping individual electrodes, and the inter-electrode distance must be kept at least 10 centimeters, EKG channel to identify the EKG artifact, and sensitivity of at least 2 microvolt per mm for at least 30 minutes recording, and there is no reactivity to any stimuli. So here we can see a generalized suppression, and even there is no cerebral activity seen even with the sensitivity set at 2 microvolt per mm.
So just to sum it up, we didn't want to make it very complicated because most of you and people outside would have seen this wonderful classification, which is all in the awake state. You should understand. Nothing about sleep is mentioned here. So when somebody says that it's for research purposes, we are wanting to know, for example, how many bloods were there from Jan 2024 to December 2024. You have a coding system for that, and you get out the bloods. But whether the plex is remaining continuously in sleep also, you won't get an answer through this classification. I'm just not trying. It's a very good classification, but there are flaws in it. That is what I'm trying to tell you. And again, I told you it can become very complicated. All this asymmetry, dysrhythmia, delta, and suppression, if one wants and one EEG is put up, you can incorporate all this into one particular EEG. And you should know the state of the patient to assume that it is asymmetry, dysrhythmia, dys or delta or whatever. And more than all this, there are benign variants which are not included in this, so we have to qualify it separately. I was telling Neena also, when we looked into the benign variants which happened in our laboratory, we'll always have to give the search words as BSSs and this and that and all. But it would have, if it would have been included in this classification, the number of cases that would have missed out would have been very difficult, very less. For example, you may be seeing a BSSS, you may be reporting it, but another person thinks that it's a benign variant. Why should I report it? So there are certain fallacies regarding that. But coming back to the nutshell of this, we'll come with to dysrhythmia. Dysrhythmia is nothing but an intermittent slowing. Again, I emphasize intermittent slowing, which can be focal, which can be in one hemisphere, or which can be generalized. But the fact is that at least at some point of time, there should be a normal background or a near normal background. That is what is called dysrhythmia. That is not complicated. Mild variant is what is called 1. And this 2 is moderate, and this 3 becomes, as she has told that we have already discussed, is all this. I forgot to include the triphasic waves. Triphasic waves comes under this. But your CJD, EEG, and SSP, we don't have a provision of including that in the the dysrhythmia or anywhere in the classification, which is important for a neurologist. You see the periodic short interval diffuse discharges, but considering the fact that they are not epileptogenic, they are only the signature marks of the CJD or SSPA, they should be classified separately. So people go on to classify it as delta grade 2 and such things and all, but it is not anywhere in the classification. So I'm not trying to find out the fallacies of the classification. Let us come to the things back. So dysrhythmia, I hope you understood. Voltage criteria and all are just very difficult. So I usually put it as 30%, 30 to 70%, and more than 70% of whatever dysrhythmia. Delta is nothing but the same thing, but it happens throughout the record, again in the awake state. If you want to qualify it in sleep, you have to again write the sleep, the same focal slowing is persisting in the body of the report. You have something called a classification where this all comes, this dis, delta, asymmetry and suppression. Then you write the, the conclusion. In the conclusion also, you have to write the sleep separately. And again comes to the body of the report. Body of the report is where you have to, expand it further and write in a very specific manner. So dysrhythmia 1 and 2 are considered to be non-specific because you are any person who is a normal person and a normal EEG, they can be drowsy in between. So you can get a dis 1 generalized in between. That is nothing. So that is why it's called a non-specific one. Dis 2 right temporal doesn't mean anything at all. One person can be drowsy and that could be just focal also. That is why it's called a non-specific thing. Delta I already described, and out of the delta, temporal intermittent rhythmic delta activity, which should be monomorphic and confined to the temporal region. By Neena, he has proved that by introducing electrodes into the hippocampus and the amygdala, when these were occurring, that is, temporal intermittent rhythmic delta activity was occurring in the scalp. This was occurring in the inside the brain as well. So that is why we qualify it as temporal intermittent rhythmic. That doesn't apply for the Pirida and Oirida. And Pirida was earlier called as zeta waves because it has something like a Z like morphology, and now it is called frontal sharp waves or frontal broad sharp waves. Whatever said and done, this is an intermittent slowing of a delta range which occurs in bilateral frontal region, and it is said that beneath that slowing there is something which is structural or whatever it is, and it can be potentially epileptogenic, but so far it is not found that it is highly epileptogenic like Tirada and Oirida already we have discussed. And coming to asymmetry, just see to it that asymmetry you qualify it only when a patient who has undergone a surgery or a trauma or a subdural evacuation comes into the picture, when you can say that the activity is increased over the surface, which is both the frequency and sometimes the amplitude and things like that. If you go into the breach itself, that itself is a 1 hour class, so we don't want to confuse anybody. And suppression, you can start from the below down. That is severe amount of suppression when there is no activity at 2 to 3 microvolt is what is called a generalized delta grade 1, grade 3 generalized, and nothing but ECI, that is electrocerebral inactivity or brain death, which Nikhil has presented already in 2 or 3 sessions back, right? Yeah. So suppression mild and moderate is just grade 1 and 2. So it's a little difficult, but I hope it made some sense to you. And now if you start classifying it, I think it will be much better. And you can add, there can be a delta grade 1 generalized, this one generalized. That what does it mean? Delta grade 1 generalized because the whole of the EEG or at least most of the record, there is a slowing which is happening. And on top of that, in some areas, there is an intermittent slowing which is popping up. So you can very well put it as delta grade 1 generalized and it is 1 generalized, which only means that on top of the generalized slowing, you have areas in which the intermittent slowing is also pronounced. Another one can be delta grade 2 generalized maximum right temporal. Only means there is a generalized slowing that is happening throughout the record in the awake state, and it is maximally expressed over the right temporal region, because as compared to the other regions, this area will show a more pronounced slowing. I hope it is clear. Any doubts from any of you? So the technologist, what is the electrophysiology behind salt bridge? Not what I described. What is common mode rejection? Who's the pioneer? Yes, Lubina. I was talking about common mode rejection only. What is that? Common mode rejection. You also, senior residents also can tell any one of you? Yes, Rohit.
Rejection is differential when uh, the activity is present. The difference between the two electrodes is what is being portrayed in that montage what we are using. So it rejects or projection of the difference is what they see. The others is the common amplitude or the common this thing is being rejected. That is what
Okay.
is not.
So whatever you said is right, but you can be more precise. So you have an input one and input two. That is what is one electrode and the second electrode. And this is exactly what I told earlier. There is a when you ask in the EEG machine system or the electrophysiological system, the most crucial thing is your differential amplifier. It is not just an amplifier; it amplifies the activity. The microvolt activity that you get from the brain comes to the electrode, and the conduction is increased through with the help of the conductive paste that you use. But more than that, it amplifies. But it's a differential amplifier, not the usual amplifiers which are used in physics and all. It's a differential amplifier for the same reason. If one electrode has the same activity plus 10 microvolt and the second one also has plus 10 microvolt, differential amplifier becomes blind and it rejects it. Common mode rejection is the physiology behind your salt bridge. So the reasons may be umpteen. The salt bridge may be due to various reasons. Salt bridge is a colloquial term which is used, but that is because there is a bridge because of the conductive paste. But what is happening really is that the amplifier cannot detect an activity which is same because two electrodes come together and they come out as an output, and that becomes one channel. I always tell you, the electrodes are there, then there is a channel, then there is a chain, and then it becomes a montage. So when it comes out, it is zero. Zero means it is a flat line. This is what is known as CMR, common mode rejection. They should know all this physics and all. This is what the technologists should know more in detail. Not that these people shouldn't know, but for you it is much more important. Anything else? Okay. Right.
Thank you for the patient listening. We will be winding up the session. Thank you.
Thanks.